I am at the University of New Mexico. I am an assistant professor in the Department of Internal Medicine, and I'm a medical anthropologist. As a medical anthropologist, I'm a predominantly qualitative investigator and researcher, but I use all of the techniques and tools that we use in anthropology, interviews, ethnographic investigation, to really answer questions in the medical field. A lot of the work I do involves health services research and what we can do to improve that for the patients that our cancer centers provide care for. We ask lots of questions. I like to take a more global approach or an ecological approach. That's how we usually refer to that, where we look at things that impact patients at the immediate individual level, but then also their social supports and their loved ones, and then more broadly at the institutional level and even societal levels. I like to really take this kind of vertical slice of society to see what it is that impacts people's care. So the questions we ask are, how can we improve survivorship care for cancer patients? Or how can we improve navigation for patients to make sure that their social determinants are addressed, such as financial concerns, behavioral health concerns, nutrition, or other things that help people recover and have stronger lives after cancer.
And about a year ago, you were asking about how sexual and gender minority folks access healthcare, particularly around cancer. And actually, let's just start sexual and gender minority versus LGBTQ. Is there any distinction between those?
It's a great question. The distinction is really an academic distinction. The National Institutes of Health, who funds most of our research, actually uses sexual and gender minority to encompass LGBTQIA+ persons. And so we typically use sexual and gender minority when writing for an academic audience. But when I'm actually working in the community, a lot of the work I do is community engaged. I'm a community-based participatory researcher. And we typically don't use SGM when in the community because that's not how people really identify themselves. They tend not to say, I'm an SGM person, but they'll say, I'm a lesbian, I'm trans, I'm, whatever. So we tend to try to use the language of the communities with whom we're working.
Right. And was SGM or like a concession to, let's say, homophobic folks who were funding?
I think at some level it definitely was. I mean, there have been periods in our past where we came up with terms like MSM, men who have sex with men, to avoid using the term gay. So there definitely is, funding at a kind of national level tends to go, very much so with who is in the office of the presidency and what the general climate of our culture is at the time. So we do come up with different terms to avoid things that are trigger terms for people.
Sure.
Our primary goal is to get as much research done as possible, not to infuriate the people on the other side of the aisle.
But tell us what it is you sort of feel you've sort of uncovered during the last year or two that's relevant to our audience.
Great. Well, I have to say, I've been working with, as a lesbian woman married to a woman with 2 kids, I've been working in the LGBTQ community for about 17 years now. So the cancer study that we're talking about today is really the result of many years of work in different fields. But about a year and a half ago, 2 years ago now, we rolled out a pilot study to look at exactly what I was talking about, these kind of multiple levels of influence of cancer care for LGBTQ people at our cancer centers. And what we discovered was, even though things are getting so much better than they were 20 years ago, 30 years ago, in terms of cancer care, there are still some gaps that we need to address to improve care for LGBTQ folks. And so we discovered that there were, in terms of cancer care, that a lot of our LGBTQ patients coming in were really very concerned before they even came in for cancer care about what the reception would be. Would they be accepted? Would their provider be LGBTQ affirmative? And so there was a lot of kind of anxiety and trepidation even prior to coming in. And we know that whenever we're trying to build services around people, that really the cancer care journey starts in the parking lot and goes all the way through every interaction you have in the cancer center and back to the parking lot and then into their homes. So, what I was really looking at is what are all of those points along that cancer care journey where we know that there are some gaps and we need to address those.
And what are the top 2 or 3 gaps you can actually see?
So I would say the top 2 or 3 are provider education is a big one, and not just healthcare providers, but the staff at the front desk, which is always going to be an issue because you have rotating staff. You don't necessarily have people there for 15 years who have taken the training. Often you're onboarding new people. So how do we onboard and train appropriately all of the people in the cancer center to be aware about how to talk about sexual orientation and gender identity data collection, for example? How do we talk to them about why that's important and how to be inclusive of their cancer patients? But the other thing that we really discovered that was challenging for cancer care providers and staff was how to include people's loved ones and social support. So real gaps exist around people's caregivers. The informal cancer caregivers in the world really take a huge burden on when they're helping to care for their loved ones. Sometimes they even have the same anxiety, stress, and physical health concerns that some of the cancer patients do, because it can be very exhausting and burdensome. And, the concern is so tremendous that it creates, a physical burden for people. So when we don't provide sufficient care and acceptance for caregivers, that's a real gap. That's really affecting someone's cancer care in a negative way. So we discovered that we didn't have sufficient social supports for those caregivers necessarily. They didn't know what that journey was going to look like for them. And then that adversely was affecting the cancer patient. And those caregivers are really significant. One of our patients, for example, when we were doing an interview with her, told us very explicitly, I don't even remember the first 2 or 3 visits. My partner, when you speak with him, her partner's transgender, he's the one that holds the memory of my cancer care. He knows what I did and what I have. So those people play a really vital role. So I think it's our responsibility to create services that help make that journey easier for them as well.
Right. So there's several interventions on training and online courses and in-person courses. Mini industry perhaps will emerge over the next year or 2 as continuing medical education credits get applied to these things. Is that enough? And the question, let me just temper the question with the idea, can training defeat an internal homophobia?
No, I don't really think it can. So, your question is that enough? I will say absolutely not. It is a first point of addressing this issue. And I don't think it can address an internal homophobia. As queer people in society, we know there will always be homophobia at some level with some people that we encounter. There's nothing we can do to change that. What we can do is look at this as a structural issue. We can say that as a structural competency, people working at cancer centers have a responsibility of treating people with respect and dignity along their cancer care journey. And we need to train people in terms of addressing that structural gap, that it's not okay to discriminate against one segment of your patient population coming in. So we can't just train. We have to create a culture as a whole that is supportive of SGM patients, and they have to know that it's a priority of the cancer center. One of the great things that's happened that helps us to have, they always say a carrot or a stick. How do you encourage people to make change? One of the things that's become more of a stick than we've had in the past is that the National Cancer Institute gives us our cancer support grants that people have when they're NCI designated cancer centers now require that, they acknowledge that SGM patients are a group of patients that are medically underserved. So now we can actually use that to say, if we want to get our cancer center designation, if we want to have this re-upped and our comprehensive status, for example, then we need to be providing adequate care and culturally sensitive and appropriate care to that population as well. So we have more tools at our disposal at this point within the last few years than we have in the past, but we still have a lot of work to do. It's really changing an entire culture to say we have to accept all patients, because we'll have those people that don't, that won't do that. Research suggests that patients being asked about their sexual orientation and gender identity and having that included in their cancer care have positive health effects for not only the patient, but also their primary cancer caregiver and loved ones as well. So I think if it becomes very unfortunate that those people can't bring their entire identity into their cancer care and cancer treatment. And if, as I've been suggesting, if that's not a priority of the cancer center, or if those questions aren't asked at a larger level, it allows those people who have anti-SGM sentiment and attitudes to really, create more space, which detracts from cancer patients' ability to be really seen. We really found that in our pilot. We did a comparative study. So we actually interviewed about 10 LGBTQ patients and their caregivers. And then we did the same with heterosexual cisgender couples. And we discovered that that was the primary difference, that when these couples, although there's like a tremendous amount of stress around cancer and cancer diagnosis and cancer treatment, when the heterosexual cisgender patients came in, they did not have that fear of how will I be received, who will be there. They didn't have the fear that their husband, wife, children would not be accepted. It was just a given that they would be there and that they would, be seen and recognized. So those initial encounters were described very differently. And that was, you get that sense of what the difference is between being a dominant culture who has that expectation of care versus someone who's really concerned about whether they'll be discriminated against.
Yeah, being a stranger in your homeland.
Yeah, exactly. So what kinds of cues can we come up with that let those people know that they're accepted when they come in? Even if it's a safe zone sticker or a rainbow flag or pronoun badges that the providers or staff wear, what can we do to let people know right away that they're in a safe place? That's really important. So I think, to your point, in these communities that are really having kind of anti-LGBTQ and particularly anti-trans legislation right now, that really inhibits a cancer center's ability to do those things that provide better care for people. We really did discover that the SGM caregivers and the heterosexual cisgender caregivers, that there was really a gap in the care that we afford to those persons. Part of it is support, whether there's a support group for caregivers. I think we need to be very mindful about creating those in cancer care spaces. And we need to have specific LGBTQ support groups for caregivers as well. People let us know that while they wouldn't mind being in the larger group, that sometimes it's very daunting to have to code switch or to be afraid that you're going to be around people who aren't going to be comfortable with you talking about the fact that your loved one is someone who's the same sex or some, a different type of relationship that they might be uncomfortable with. Another thing that we discovered that really has been found in other research is that LGBTQ caregivers aren't the same as heterosexual cisgender patients in terms of who they are. Where a lot of our heterosexual cisgender patients had broader family, like biological family networks, that was not the case for our LGBTQ caregivers. They typically relied much less on their biological family for care. They had chosen family, they had other supports that were there. I really see that as a strength and a point of resilience for LGBTQ cancer patients, to be honest. I think that's something that LGBT patients could really, and caregivers could demonstrate and model for heterosexual cisgender patients about the power of those chosen family networks. But when it came down to it, we discovered that just the lack of support in general, the lack of a roadmap, was something that the social supports were missing all across the board. And they were talked about, stepping into this position where suddenly they were trying to make financial decisions about someone's cancer care, and they had no idea how to do that. Or, getting them to the care, remembering all of these pieces of their cancer care journey and diagnosis, treatment, what they were doing. All of these things were, it's very stressful for the cancer patient, but the caregiver is the one that's so invested in their well-being and their survivorship, how they succeed in that. So I think we really need to work on how we can support caregivers all across the board.